Hello, thank you for joining us for our quarterly webinar here at Genoa on the Horizon Novel Approvals and Pipeline Medications in Behavioral Health. My name is Jennifer Heath, and I'm a clinical pharmacist by background, and I direct the design of our clinical programs here at Genoa. Today I have with me Allie Dingus, who is a clinical pharmacy manager supporting our telephonic clinical programs, and Bill Wrigley, who directs our immunization program. I almost considered naming this presentation Clinical Potpourri, as I will be providing a wide range of updates to you today. My goal is that you walk away from today with learning something that excites you. I will start with some updates in the behavioral health space in terms of novel approvals, expanded use, and labeling updates. I'll then touch on a few agents in the pipeline and then shift gears to providing some exciting updates on vaccinations. We do have time for your questions at the end of the presentation. Please use the Q&A feature in your Zoom browser to submit your questions. This is separate from the chat feature, so please know that and use the Q&A throughout. We will also have a few pauses for poll questions that will pop up on your screen. I encourage you to participate as you're able to. Jumping right in with one of those polls, I'm interested to know, how do you stay up to date on new drug approvals as they hit the market? So again, you should see a pop-up window on your screen. And we'll give it a minute or so here.
All right, so it looks like about 7% of you actually said other. I'd be really interested to know what you use. So if you could throw that in the chat, I think it'd be something we'd all be interested in seeing and learning. I am surprised only 3%. It's something that I feel like I use a lot, a social media account. So if there are any that anyone highly recommends, we'd also love to see that thrown in the chat as well. Pretty solid between professional society communications and drug company marketing materials at about a third and a third each there. So this doesn't surprise me too much. Any comments you want to add in the chat, go ahead. I'll pass this back over to Jen.
All right, thank you. And thank you for participating. I love seeing where people find their information. Okay, so before we get into the specifics around some of the new drugs available on the market, I thought it might be helpful to start with a very brief overview of the drug approval process in the US. The FDA's Center for Drug Evaluation and Research, or CDER, evaluates new drugs before they can be distributed. CDER ensures that drugs are effective and that the benefits to health outweigh the known risks. There are 3 general stages to drug approval in the US: preclinical, clinical, and NDA review. During the preclinical phase, the drug sponsor develops a new drug compound, which is tested on animals for toxicity. Multiple species are used to gather basic information on safety and efficacy of the compound being investigated. And then the sponsor submits an investigational new drug application to the FDA based on the results from those initial tests. In that application, they include the composition of the drug, the manufacturing process, and they develop a plan for further testing. The second stage in the drug approval process involves clinical trials to test the new drug on humans. The trial phases have various numbers of enrollees, and the research emphasizes safety, efficacy, and dosing. Phase 1 trials are the smallest of the 3 phases, usually conducted on less than 100 healthy individuals. This phase emphasizes safety. The goal of this phase is to determine the drug's most frequent side effects and often how the drug is metabolized and excreted by the body. In phase 2, the number of patients is expanded to the hundreds. This phase emphasizes efficacy. The goal is to obtain preliminary data on whether the drug works in people who have a certain disease or condition. And then this brings us to phase 3, what's most familiar to most of us working in healthcare. The typical number of patients used in phase 3 is in the thousands. These studies gather more information about safety and efficacy, study different populations and different dosages, and uses the drug in combinations with other drugs. Once the drug sponsor has completed their phase 1, 2, and 3 clinical trials, they're ready for the new drug application step. The NDA stage includes a rigorous process of meetings, data review, and inspections by the FDA. All data from studies completed in the prior two stages are included in the NDA, as well as information regarding the manufacturing process. Once the NDA is submitted, the FDA has 60 days to decide whether to file it so it can be reviewed. During the review, in addition to evaluating the research on safety and efficacy, the FDA reviews the drug's professional labeling to ensure appropriate information is communicated to healthcare professionals and patients. At the drug approval step, the FDA reviewers will approve the application or issue a response letter. So with all of those steps, it takes on average 12 to 15 years for a new drug to go from invention to market. With that in mind, I thought it'd be interesting to show new drug approvals from the past decade. CDER has averaged about 43 novel drug approvals per year during the past decade. In 2021, 50 drugs were approved by the FDA. So far in 2022, there have been 16 novel drug approvals. Before we shift gears into some actual drug updates, I want to know what makes you comfortable prescribing new medication options to your patients. Again, please use the poll options on the screen.
It looks like about half of the crew here says combination of the above, which is great, using definitely different resources along the way. And I see 17% utilize your pharmacist. I personally, as a pharmacist, think this is awesome. So continue to use your pharmacist as your resources there. I'll hand it back over to Jen.
Awesome, thanks for sharing, everyone. It's definitely a combination of the above for me. There's lots of places to receive that information and make decisions about therapy going forward. All right, so as mentioned, there's been 16 new drugs approved this year. So far, only one of those novel approvals is in the behavioral health space. So that is the drug I'm going to talk about first today. So QUVIVIQ, or daridorexant. QUVIVIQ was approved in January 2022 and is a dual orexin receptor antagonist, or DORA. It joins Dayvigo and Belsomra in this class. Of the now 3 available DORAs, QUVIVIQ has the shortest half-life at approximately 8 hours. This is practically a good idea for a sleep agent, as to not have drowsiness carry over into the next day. In clinical studies, both the approved doses, the 25 and 50 milligram, significantly improved sleep latency and maintenance, which were the primary endpoints, as well as improvement in subjective total sleep time, which was the secondary endpoint. This increase in sleep was reported starting after week 1 and built over 3 to 4 weeks. The change from baseline in the treatment groups increasing by an average of 48 to 58 minutes at month 3. The 50 milligram dose also provided statistically significant reduction in patient-reported daytime sleepiness reported at week 1. Now, I don't have time to jump into all of their data today, but it is interesting to review the raw numbers and minutes for improvement in these sleep parameters. Patients taking QUVIVIQ improved their time to fall asleep from about 65 minutes to 30 to 35 minutes, which, when you think about it from a quality of life standpoint, seems quite impressive. But as always, we really have to consider the placebo response in the trial as well, because those who received placebo also responded, falling asleep about 20 to 25 minutes faster, with a difference between treatment and placebo being just 12 minutes for the 50 milligram dose and 8 minutes for the 25 milligram dose. This is not meant to be overly critical of this medication, as you'll see similar things among other approved sleep medications. But I think that this can be a really important thing to consider when we're setting expectations with our patients. This medication will help them fall asleep faster by potentially cutting the time it takes to fall asleep in half. So it really depends what their baseline is, and they shouldn't expect to fall asleep instantly. So as always, I have to note, insomnia is multifactorial. Other prescriptions, OTC drugs, alcohol, nicotine, caffeine, control of other conditions like depression and pain need to be considered. So while this isn't going to change much about clinical practice from my perspective, it's another option within this class for the right patient, perhaps when we're wanting to avoid a benzodiazepine or in those with mixed insomnia or sleep maintenance concerns. Though not a novel drug approval, the second new drug in the behavioral health space is dexmedetomidine sublingual film, branded as ILGALMI. This is a new formulation of dexmedetomidine approved in April to treat acute agitation in schizophrenia or bipolar disorder. Dexmedetomidine, which you may be familiar with under the brand name Precedex, is available IV or via nasal atomizer for sedation and anesthesia. ILGALMI is a selective alpha-2 agonist, and its action results in inhibition of norepinephrine to induce calm. Given this action, monitoring of vital signs is required and will be required for the self-administration of this drug by a healthcare provider, as we need to watch for low blood pressure and orthostatic hypotension. It's worth noting that there are several antipsychotic formulations FDA approved for agitation associated with schizophrenia, but only 2 of them are also approved for agitation and bipolar disorder, and that would be injectable olanzapine and inhaled loxapine. So ILGALMI joins those options to be available in agitation for either condition. ILGALMI is available in 2 strengths. The 120 microgram dose can be given for mild or moderate agitation, and 2 additional half doses can be administered at least 2 hours apart if agitation persists. So these sublingual films can be cut to allow for those repeat doses. The 180 microgram dose should be reserved for severe agitation, again with the half dose administered at least 2 hours apart. It is interesting to note that in the clinical studies, less than 20% of patients actually needed a repeat dose. The most common side effects reported in the clinical trials were drowsiness, dry mouth, hypotension, and dizziness, which weren't unexpected, and there were no serious side effects reported. This is an appealing option to include for agitation, given it is self-administered by the patient themselves, while it still does require that supervision, but it is generally well tolerated without oversedation, which you could see with other medications for agitation. The response to therapy was seen as soon as 20 minutes after the dose, and after 2 hours, 77 to 90% of participants in the treatment group in the studies achieved a clinically meaningful drop in agitation. That was dependent on the dose, with the higher response range being with the higher dose. This was a significantly higher proportion than those who were in the placebo group. 46% in that group achieved a clinically meaningful drop. The authors noted that a high placebo response was not unexpected, as all patients, regardless of treatment, received careful monitoring and de-escalation techniques. The drug sponsor, BioXcel, is currently studying sublingual dexmedetomidine for agitation related to dementia as well. Oops, excuse me. All right, so just as there are new drugs approved every year, there's often indications, strengths, expansions of use for current medications. I'll be covering a few key updates in this area as well. The first drug in my expanded use section is Caplyta, or lumateperone. Caplyta is a second-generation antipsychotic, first approved in December of 2019 for schizophrenia. Then 2 years later, in December of 2021, it gained approval for bipolar 1 and bipolar 2. Either as monotherapy or adjunct treatment. This is only the second medication in the class to be approved for bipolar 2, joining Seroquel. Its administration is appealing in that it's a once daily medication, does not require titration, and can be taken with or without food. The standard dose for all indications is a 42 milligram capsule. An update in this year is that 2 new strengths are now just becoming available across the US. A 21 milligram capsule and a 10.5 milligram capsule. And this is for use in specific populations. The 21 milligram capsule can be used in patients with moderate or severe hepatic impairment. Previously, the labeling noted to avoid use in liver disease. There are also recommendations for use with concurrent CYP3A4 inhibitors. The half strength will be for use with moderate inhibitors, and the 10.5 milligram dose for use with a strong inhibitor. The next medication is Qelbree. Qelbree was approved last year for the pediatric population ages 6 to 17 years. In May of 2022, it was also approved for ADHD in adults. due to positive results from a phase 3 study. Qelbree represents the first approval of a novel non-stimulant treatment for adults in 20 years. Qelbree works by blocking the reuptake of norepinephrine, and while the exact mechanism for benefit in ADHD has not been fully identified, some data suggests that it inhibits 5-HT2B and activates 5-HT2C. To briefly compare the dosing, now that it's available for both peds and adults, the starting dose ranges from 100 milligrams to 200 milligrams, with the lower dose in people under the age of 18 at 400 milligrams, and the max dose of 600 milligrams in adults. The medication can be titrated weekly according to the package labeling, and there are dosing recommendations for severe renal impairment when eGFR is less than 30. For reference, in this study, 60% of participants in the adult study were on the maximum 600 milligram dose, and 32% were on the 400 milligram dose, titrated based on response. As far as safety, most common side effects reported are insomnia, headache, fatigue, nausea, and decreased appetite. Well, not for behavioral health, I squeezed in this update regarding Cabenuva, which is the long-acting injectable medication for people with HIV. Given HIV is a risk factor for mental health conditions, it is a medication that we are seeing more and more commonly. Cabenuva was first approved in January 2021 for HIV treatment in adults who are virologically suppressed. It's a long-acting injectable medication containing both cabotegravir and rilpivirine. And in March of 2022, it was expanded to include an indication for adolescents 12 years and older. There are also some important labeling updates since it's been approved based on ongoing studies. In February of 2022, an additional maintenance dosing schedule was added to the label, with a new dosing schedule allowing for every 2-month maintenance dosing instead of every 1 month. The standard monthly regimen is a one-time initiation injection at a higher dose, followed by a lower monthly dose. Now, the higher initiation dose can be administered 2 months in a row and then continued every 2 months. The other update as of March was changing the oral run-in period from required to optional. This allows patients starting Cabenuva to start the injection the very first day it's prescribed. My last update is an important safety update released by the FDA in early 2022 regarding transmucosal buprenorphine containing medicines. It's something our pharmacists are being diligent about counseling on, as it's something that we've been seeing isn't as known. The FDA warning described the potential for dental problems, including tooth decay, cavities, oral infections, and tooth damage, sometimes resulting in removal or loss of teeth. These problems have been reported even in patients with no prior history of dental issues. So this warning has been added to the medication guide for prescribers and patients. The true incidence of dental problems with buprenorphine is unknown. However, patients using these products should take some extra steps to minimize risk. Patients should be educated to swish and swallow after the medication has completely dissolved, and to wait at least 1 hour before brushing their teeth to allow the mouth to return to its natural state to avoid potential damage to the teeth. Patients should also be counseled to see a dentist soon after starting the medicine and during treatment. As I mentioned at the beginning of the presentation, the drug pipeline from invention to approval can take 10 to 15 years or more. I have a couple of investigational agents to share with you that have had some recent updates in their later phases of study in the drug approval process. The first agent is zuranolone. Zuranolone is an investigational drug in the development for the treatment of major depressive disorder and postpartum depression. Zuranolone was developed as an improvement to brexanolone, an IV drug which is approved under the brand name Zulresso for the treatment of postpartum depression. Zuranolone is a neuroactive steroid that works through positive allosteric modulation of GABA A receptors. It is given orally for 2 weeks, either as monotherapy or co-initiated with a standard of care antidepressant. Sage Therapeutics and Biogen have initiated a rolling NDA submission for zuranolone in the treatment of MDD and plan to complete a full NDA filing for MDD in the second half of this year, with filing for postpartum depression to follow quite quickly in early 2023. The most recent results to be announced at the beginning of this month were from the Skylark study in persons with postpartum depression. Zuranolone demonstrated a statistically significant improvement in depressive symptoms at day 15. The study met all key secondary endpoints with rapid and clinically meaningful improvement in depressive symptoms seen as early as day 3 and sustained at all measured time points through day 45. This will be an exciting medication option to watch for. The next drug candidate is not quite as far in the drug approval process. The investigational drug NRX-101 is a fixed dose D-cycloserine and lurasidone combo. It's being studied for severe bipolar depression in patients with acute suicidal ideation. It was granted breakthrough therapy designation and has begun enrollment in their phase 2 clinical trial in a subacute population not requiring hospitalization. In this study, NRX-101 is being compared to lurasidone alone for remission of symptoms of depression and suicidal ideation over a 6-week period. There is also a current phase 3 clinical study in the inpatient setting in those with active suicidal ideation. A single dose of their investigational NRX-100, which contains ketamine, is administered to stabilize the condition, followed by the initiation of NRX-101. The last medication to have on your radar is an additional LAI formulation of risperidone. As you know, there are 2 LAI options for risperidone on the market currently for adults. Risperidone Consta, given IM, typically every 2 weeks, and Perseris, which is administered monthly subcutaneously in the abdomen. This new extended release risperidone candidate is being studied in ages 13 to 65 years as both a monthly injection or an every other month injection. Both dose schedules were associated with a statistically significant with a statistically significant delay in the time of relapse compared to placebo. The submitted NDA includes phase 3 data from 2 pivotal studies, the RISE and the SHINE studies, which evaluated the efficacy and long-term safety in patients with schizophrenia. Those treated with the investigational risperidone, whether it was given monthly or every 2 months, experienced that significant delay in time to relapse compared to those who received placebo. The study also met secondary endpoints with an improved proportion of patients in pending relapse and patients deemed stable at 24 weeks. The FDA has issued a complete response letter to the drug sponsors recommending next steps. This does delay the approval, but is a standard part of that NDA process. And the sponsors have noted via press release they're committed to addressing identified deficiencies and pursuing resubmission. Timing of this resubmission is yet to be determined at this point. Switching gears to a different drug pipeline, I'm going to provide some updates on vaccinations. In addition to the ever-changing COVID-19 vaccine recommendations, there are also some updates to the 2022 general immunization schedule for adults that I'd like to call your attention to. So before we get to those updates, I want to pause for another poll. I want to know who at your clinic currently administers vaccinations.
Looks like over half of you indicated that your pharmacy team does currently administer vaccinations for you, which is great. And another large chunk there at close to 40% said your nursing staff. It seems like a lot of you are aware, but we do provide vaccinations at Genoa for influenza, COVID-19, and many other conditions. Many patients have fallen behind on standard vaccine schedules given the pandemic. So if you need assistance in catching patients up or have any questions, our pharmacists can definitely help you out. All right, Jen, I'll pass it over to you.
Awesome. Thanks, Allie. Okay, so it's amazing how far we've come with COVID-19 vaccines since the initial approval over the past year and a half. This is an oversimplification of the current CDC recommendations by group, recognizing that there is nuance for people with certain health conditions. I have a big star listed for kids under the age of 5 since the FDA Advisory Committee voted to authorize these vaccines yesterday. So it's been an exciting June in general for COVID-19 vaccines. On June 7th, the FDA voted to authorize Novavax, which if it's approved by the CDC, will be our fourth vaccine option in the US. Novavax is approved in many other countries across the globe. It's a 2-dose protein subunit vaccine with an adjuvant. It's using technology that's been available for much longer, making it an option for those who were hesitant to use an mRNA vaccine or those who did not tolerate an mRNA vaccine. Given it's the fourth vaccine option, its place in therapy may end up being primarily as a booster. Current trials in adolescents for Novavax, as well as booster and a co-administered flu and COVID vaccine, are currently ongoing. The CDC will have to meet and make the recommendations on this vaccine. Then on Tuesday, the Moderna EUA request for ages 6 to 17 received a unanimous yes, moving another vaccine forward in this group. Then after much anticipation, yesterday the FDA Advisory Committee voted to authorize both Moderna's 2-dose vaccine for ages 6 months to 5 years and Pfizer's 3-dose vaccine for ages 6 months to 4 years. The CDC Advisory Committee is meeting tomorrow and Saturday, and vaccines for kids under 5 could be available in certain places as soon as next week. I also wanted to provide a brief reminder about boosters. The newest group to have boosters approved includes those ages 5 years to 11 years. Children in this age group should receive a booster shot 5 months after their initial Pfizer vaccination series. With the approval of the Moderna vaccine from the FDA, we will have to wait to see what the CDC says for guidance among that vaccine. Booster doses in this age group did increase vaccine effectiveness back up to 71%, which is particularly important for the protection against Omicron and other variants. Immunocompromised children may receive a booster in addition to 3 full doses. And then as a reminder, the second booster shot for adults is recommended above age 50 and in those above age 12 with certain health conditions. There is not an approved second booster for the general population under age 50 at this time. So what is the future of COVID-19 vaccines? The FDA is also holding a meeting at the end of the month on June 28th to further discuss an approach going forward. They're going to be looking at things like how to potentially modify strain composition of vaccines to address variants, how often to consider the changes in strain composition, the optimal frequency and timing of any future doses, and how to implement a formal process for COVID-19 vaccine strain selection in general, similar to how there is the standard process for the flu vaccine. A big vaccine update outside of COVID-19 is in regards to pneumonia vaccination for adults. There were 2 recent vaccine approvals, Prevnar 20 and Vaxneuvance. Both new vaccines cover the same 13 serotypes as Prevnar 13, with some additional ones included. The newer vaccines appear to be more expensive, but the CDC reports that they can still, they expect that the cost savings with the additional serotype coverage will make up for the anticipated reductions in total cost of care. So pneumonia vaccination is recommended for adults 65 years and older and in younger adults with certain health conditions. The list of health conditions is quite expansive. This is something that we commonly see as a gap where many people would qualify for the pneumonia vaccine and just don't realize it. They include things like cigarette smoking, alcoholism, any chronic lung disease, heart disease, diabetes, and many other conditions that cause someone to be immunocompromised. The biggest change overall in the recommendation for pneumonia vaccines is that Prevnar 13 is no longer recommended for initial vaccination for adults. If Prevnar 13 was used, the same recommendation for following it with Pneumovax still applies. And then going forward, if someone who has not received a pneumonia vaccination or has only received Pneumovax, a dose of Vaxneuvance or Prevnar 20 is recommended. If the patient receives Prevnar 20 as their initial vaccination, there is no need to administer Pneumovax 23, which simplifies things, making it a one and done vaccination for adults. And my final update for you, the herpes zoster vaccine to prevent shingles now is recommended for use in people ages 19 years and older who are or will be immunodeficient or immunosuppressed because of a disease or therapy. This was previously recommended for age 50 and above only. So Shingrix, as you know, is the recombinant zoster vaccine and is a 2-dose series. The second dose is administered 2 to 6 months following that first dose. For persons who will be immunodeficient or immunosuppressed and they would benefit from completing the series in a shorter period, we can do that. The second dose can be administered 1 to 2 months after the first. Better late than never is the rule for those that miss their second dose. If they miss that 6-month range, it can be given any times after 6 months without having to repeat that first dose. And that brings me to the end of my content today. I'm going to have Allie and Bill join me, and we will take some questions from the Q&A.
All right, I already see some coming in during the presentation here. Jen, I'm going to feed one here to you to start about the Ilgami. They said just for agitation, it does not treat underlying conditions, correct, like clonidine?
Correct. I think that was my perspective on the use would just be in the acute setting, given that it is a kind of a one-time dose with some repeat doses. I do not believe in the way it's intended to be dosing that it would be used to treat like as a maintenance treatment, for example. I am curious to see too whether or not it will be something that's available both inpatient and outpatient. Given the self-administration, you know, it could potentially be something available in clinics to administer, but I think we just don't know that yet.
Great, thanks, Jen. Another question that they have here about the COVID vaccines. Are any of the vaccines actually approved, or are their authorizations still based on an emergency use approval?
Oh, great question. That one that I'm going to pull Bill in to give us an update on that. I know for anything that's under an EUA, which is anything I covered today, none of those have a full approval to this point. So Novavax, anything for under age of 18 for Moderna, and then the under 5 for Moderna and Pfizer. All of those are available under EUA. Bill, can you join me to give an update on which ones are fully authorized?
So the Pfizer and Moderna vaccines, I believe, have full approval for some of the kind of initial applications that were submitted, which would be adults 18 over, and with the initial schedule, potentially a booster. But then as they kind of add more guidance, you know, in kind of the normal process of evaluating boosters and things, those and younger age groups, those typically fall under still under the EUA. So it's kind of a partial, I guess, approval where some of the older, because they have enough data now, older conditions under which they were approved have the full FDA approval. But then, like I said, everything that Jen mentioned today, the under 18 Moderna and the under 5 for Pfizer, those would still fall under kind of the EUA bucket.
Great, thanks, Bill. There's also a question here about variants. What variants of COVID are the vaccines effective in protecting people?
I'll start, and then Bill, if you want to jump in and add anything. I think when we think about vaccine effectiveness, there's kind of two big categories, right? So we're looking at how effective is the vaccine at preventing infection, and how effective is the vaccine at protecting us from severe outcomes. So those would be things like getting admitted to the hospital or death. And so when we look at the vaccines, a lot of time what's reported generally widely by the media is that general overall vaccine effectiveness. So when you hear about percentages coming out, and as I mentioned, for example, like the vaccine, the boosters for age 5 to 11, vaccine effectiveness went back up to 71%, giving us more coverage against some of those variants. So a long-winded answer to say that, they're not so specific that they target, just one variant, but what we've seen with current circulating variants is that there is still some protection and very high protection against severe illness. And so there are some variant-specific studies going on with, I believe, all of the major players in that space. And that's part of the decision that the CDC is going to, or the FDA is going to review kind of end of month, is what do we do going forward to target emerging variants? And then the other piece that makes us leaps and bounds ahead of where we were when vaccines originally came out is, you know, so many people have been infected with COVID. We see a big mix of, you know, the protection that is gained from vaccines and the protection that's gained just from having an infection, with the more consistent protection coming from vaccines. But, you know, we're in a much better place to handle some of these emerging variants, just given the baseline immunity in the population. Anything you wanted to add about variants, Bill?
Yeah, not too much. I think you really kind of gave a good overview of where things are at. But how I typically think about it is, as far as reducing transmission, usually with you know, like a booster, there's a new booster authorization, right? Someone that gets that booster will get that spike in antibodies, and you know, probably have a decent period, maybe 4 to 6 weeks post that dose, where they're probably you know, protected from getting transmission to them and transmitting to others. But that drops off, you know, relatively shorter period of time. But the kind of underlying and more important protection of preventing hospitalization, severe disease, and death, that seems to be more lasting regardless of the variant. So that's kind of how I think about it anyway.
Thanks, Jen and Bill. One last question that I see here in the Q&A, what is the difference on the new risperidone? I know there is already a subcutaneous risperidone on the market currently.
Yeah, I'll do my best to cover that. The big thing with the new one is just that they're studying it, I believe, for the extended period. So the current one on the market is a monthly maintenance injection, and the one being studied does include a wider range. It includes adolescents, but it is being studied monthly and every 2 months maintenance. So would be another option in that respect. So as far as the drug composition, that's something off the top of my head, I'd have to double check the technology on the way that, you know, the deposit allows it to be the longer administration. But yeah, that'll be interesting to see, especially if we have 2 options, you know, where their place in therapy will become. So that's kind of my best shot at that question. And I can also go into a longer answer when we post the blog post about this webinar, if you'd like.
There's another related question here about this, Jen, asking where that sub-Q risperidone is administered, and if you're aware of what that utilizes for needle gauge as well.
I'm going to add that to my come to the blog post when you go to find it to share with your colleagues, and I will get that updated. I'm not sure if they have, I'm sure it's in their full protocol of the needle gauge and such, and I can check the sites of administration for that as well.
Awesome, Jen. There was one here, Jen, that I think that you could speak to. It was actually in the chat that I saw earlier. Someone said, I actually feel like we are very sheltered by new drugs or generics being released. Is there a better way? What would you recommend, Jen? I always go to you for this.
Yeah, I mean, there's a number of ways to stay up to date on drugs that come to the market. The FDA website actually keeps a running list. And these are resources I'm happy to include when we do provide the materials from this webinar. The FDA keeps a running list of drugs. It's not in the prettiest form. If you clicked on it, it would take you like directly to clinicaltrials.gov, which is often a ton of information to address. The other place that I think it is, just like drugs.com, that general patient-facing database, they have a section on novel drugs that has all these like press releases. It contains everything, not just like in the behavioral health space, but can kind of, you know, keep you abreast of what updates are out there and when things are moving through the drug approval process. The third place, depending on what information is available to your clinic system. Up to Date is a database that I personally have access to, and they have a new drug section. And the nice thing about that one is you can get it down to the disease state level or broad level, like neurology or behavioral health. And then they also break it down to having one section where the updates are based on which are the ones that are going to change practice, right? Because often there's a lot of drug expansion and things that happen that, you know, they aren't groundbreaking. They'll slightly change our practice habits, but it'll take some time. But there are some of those, you know, landmark trials and things to start to be aware of, and that can be a place for that. So we'll include that when we share the materials, some ideas of where you might be able to find information. And if your health system has access to different databases, I'm sure that they may have similar areas to look for that kind of stuff. That's a really great question.
All right, one last one that I see here related to flu shots. Are there any flu shots for self-administration?
I'm going to hand that to Bill.
I do not know of a flu vaccine presentation that is specifically designed for self-administration. Something we can probably,
I don't
you
either.
mentioned a blog post where there may be some follow-up look into, but I have not heard of something that's marketed specifically for that delivery mechanism.
Thanks, Bill.
Yeah, well, great. Well, I want to thank all of you for joining us today virtually in this environment. We'll be sending out, like as I said, we'll send out a recording. It'll be available on our website. Feel free to share it with colleagues. You know, we want to be a source of information for you, so please reach out to us. If you have any other questions that come up, you know, or you have a request for a future topic you'd like us to cover, you're interested in having a COVID-19 or flu vaccine clinic, you know, please send us an email or reach out to your site pharmacist or DOO. They'll be happy to connect you with the right people. So again, thank you and have a great week.